Good morning, my dear students. Meeting you after a long gap. You have to remember that neither human beings are going to extinct from this world nor this COVID-19 virus. We have to coexist. So in this crunch moment, I have chosen topic antibiotic for today's discussion. Antibiotic is defined as a substance which is obtained from a microorganism, either kill or prevent. As I said before, antibiotic is a substance, as the classical definition, which is obtained from a microorganism, that means from a natural substance. But there are plenty of substances, plenty of drugs, which are killing microorganisms, but not obtained from a natural origin. Now, these are coming under the category of antimicrobial agents. So it's a broader term. It means that the drugs which are synthesized in the laboratory precisely can be called antibacterial agents, as well as those obtained from fermentation of microorganisms are included in the division of antimicrobial agents. By the term chemotherapy, we mean the treatment of systemic topical infection with drugs that have selective toxicity for an invading pathogen, either living or multiplying, without much harmful effect on host cells. But so, considering the fact that a patient presented with some kind of infection, we have decided to make a strategy for our treatment. Most of the clinical people, they are following these kind of protocols when they are getting patients with different kinds of infections. Now, there is a time when it is not possible for you to isolate the organism or identify the organism, like in case of septicemia, and at that point it is always better for you to use a broad spectrum or extended spectrum antimicrobial agents. Whereas if you can prove that it's definitely due to some kind of bacterial infection, which may be gram positive or gram negative in nature, or if you can specify the bacteria and the sensitivity towards a particular antimicrobial agents, then you must select that. And ideally, it should be a narrow spectrum, but it is again depending on the sensitivity. It can be. So how will you classify antibiotics? So before coming to the classification, let us have some idea about invention of antibiotics, and that is considered as the history of medicine. The magic bullet, the concept of magic bullet, is invented by Paul Ehrlich, who is known as the father of modern chemotherapy. He successfully cured syphilis using organic arsenicals, that is known as salvarsan. But he found that it was not effective against any other organisms, and hence this led to the search of sulfonamides. Nomack found that the antibacterial effects of an azodide, prontocin, and this is tested its effect in mice infected with streptococcus. The antibacterial effects of prontocin were striking, both for preventing a possible streptococcal infection and for treating the already established infection. Later on, it was used for puerperal sepsis, and it's reduced the death of many women after childbirth. Later on, this been recognized that it is converted when its active moiety called sulfanilamide, and that was responsible for the antibacterial effect. But a good number of sulfonamides were discovered till Alexander Fleming discovered penicillin and penicillin-like drugs, and it's becoming therapeutically available in 1940s. Discovery of such drugs such as aminoglycoside, tetracycline, chloramphenicol, these are coming after 1950. Now, coming back to the classification, antibiotics can be classified on the basis of its mechanism of action, on the basis of the fact that whether it is going to kill a microorganism or it will prevent the growth of a microorganism. If it kills, it is called bactericidal. If it is preventing the growth of microorganisms, then it is called bacteriostatic. Now, for the extreme of age groups, like where the immunity is not well developed in children or immunity is quite suppressed in elderly patients, it's always better to go with the cidal ones. The example of bacteriostatic drugs are tetracycline, chloramphenicol, whereas the cidal ones are penicillin, ciprofloxacin. As I said before, that the spectrum of activity can be classified into three types. It can be broad, it can be narrow, or it can be extended spectrum. Narrow spectrum means it is only restricted to a particular type of bacteria, either gram-positive or gram-negative. Broad spectrum means it's covering not only bacteria but also chlamydia, mycoplasma, protozoa, and other organisms. Whereas the extended spectrum means a gram-positive antibiotic. Extended. So coming back to the basis of classification, the bacteriostatic ones allows for natural immunity to deal with the microbes, so you have to depend on your own immunity. It is obviously prescribed in case of the infections where it's happened in an adult, in a young person, but ideally it should be avoided in children as well as in the elderly patients. Whereas the bactericidal ones are always preferred. They lead to release of toxins and microbial contents leading to subsequent illness and inflammatory response, but those are very specific drugs, and you always have to remember this will. So on the basis of the spectrum of activity, it can be classified into three types. The narrow spectrum one, where it is only restricted to gram-positive or gram-negative bacteria. Penicillin G is basically a narrow spectrum drug, but as it is only effective on the gram-positive organisms, but there are some drugs from the same group of beta-lactams like amoxicillin, ampicillin, the drugs like piperacillin, which have extended spectrum. They will start covering the gram-negative bacteria, hence they are categorized under extended spectrum drug. And there are only two. On the basis of mechanism of action, we can classify the drugs in different types. Those which are inhibiting cell wall synthesis are penicillin, cephalosporin, vancomycin, these kind of drugs. The cell membrane destroying antibiotics are polymyxin B, the amphotericin B. These kind of antimicrobial agents. There are some protein synthesis inhibitors like tetracycline, chloramphenicol, the macrolides. So drug is orally ingested. It is going into the circulation following GI absorption, and then from there it is either going to the extracellular compartment, like chloroquine is deposited in the liver and in the retina. So retinal toxicity is very common with chloroquine, whereas, so as I told you, to understand the concept of time dependent and concentration dependent antibiotic, one has to understand the concept of MIC and MBC. Susceptibility testing is often performed by automated systems based on broth dilution method. This method detects the lowest concentration of the antimicrobial agent, which prevents the visible growth of microorganisms after 18 to 24 hours of incubation. This concentration is referred to as minimal inhibitory concentration, or MIC. So these are in serial dilutions, and you see the minimum concentration in which we are not seeing any visible growth. So that is in vitro termed as MIC, minimum inhibitory concentration. And when we are extrapolating it into the clinical practice, most of the times we are keeping it 4 to 8 times above that MIC level. So the concentration of the drug in vivo in human blood is going to be most of the times 4 to 8 times higher than MIC level. Now the broth contains antimicrobial agents in serial dilutions, as I mentioned before, which are likely to correspond to levels achieved in humans. The same test procedure can be extended further to determine minimum bactericidal concentration, or the minimum concentration that kills 99% of the microorganisms. Now see, from here it is transferred to the culture medium, the agar medium. It's a subculture being taken place, and here we are seeing the percentage of microorganisms killed, that is 99%. Whereas in case of MIC, the definition was there was no visible growth. So before going into the concept of time concentration and concentration dependent and time dependent we have to recapitulate our initial idea about drug pharmacokinetics. So let us go through this. The concentration present for 50% of the dosing interval, 6 hours if given at an interval of 12 hours. Maybe this is standardization of minimum effective concentration. This is the topmost point, the Cmax. Now when just extrapolating the whole thing in terms of antibiotics, we are placing antibiotic concentration with time, and we are seeing that there is a certain concentration which is called MIC level, which is basically cutting through and is depicted via dotted line. For you, you can consider this minimum effective concentration for other drugs can be considered as the minimum inhibitory concentration in case of these antibiotics. Now 24-hour AUC and MIC is correlated with outcome of infection, the magnitude required for success, and MIC at which this occurs becomes the pharmacodynamic breakpoint. Now on the basis of this, you see that the area under the curve, which is lying above MIC level, is becoming extremely important, because there is a term called time dependent action. The time dependent means the time for which it remains above this MIC level, that part is going to be effective. Whereas in case of concentration dependent killing, we are seeing that the antibiotics are more effective in higher blood concentrations, and these are reached periodically. These exhibit concentration dependent killing, whereas the time dependent killing is seen by the length of time for which it is a drug. So the time dependent killing action is depending or correlating with the pharmacodynamic parameter of time above MIC, whereas the concentration dependent killing action is depending on the bioavailability, hence it is depending on AUC by MIC ratio, or peak by MIC ratio, or Cmax by MIC ratio. So there is a difference between these two types of drugs, and this is again the basis of classification of antibiotics. One more term which is extremely important in relation to this activity of antibiotic is known as post-antibiotic effect. This is the persistent suppression of bacterial growth after a brief exposure of an antimicrobial agent, and in post-exposure antibiotic effect, the inhibition of bacterial growth is seen even when the antibacterial agent is no longer present in the bacterial medium, or even when its concentration is well below MIC level. The post-antibiotic effect therefore reflects the time required for the bacteria to return to normal growth. Longer the time the bacteria needs for return to logarithmic growth after an exposure to antimicrobial agent, the greater is the post-antibiotic effect of that particular antibiotic. Hence, many antibiotics we have seen that exhibit post-antibiotic effect. Whenever we utter this term that the drug is not effective against a particular bacteria, normally we termed it as resistance. But the resistance, the word resistance can be replaced by the term tolerance. Now these kind of drug resistance, or if you say antibiotic tolerance, can be classified into two types. It can be natural, it can be acquired. Natural resistance are pretty common in nature, like the Mycobacterium tuberculosis, which is naturally resistant to tetracyclines. They are not getting any kind of action on the tubercular bacilli. This is natural because tetracycline doesn't have the capacity to penetrate the cell structure of Mycobacterium tuberculosis, or its preventive activity on the growth is not effective on the same. Whereas the acquired resistance is basically depending on two things. The first thing is called mutation. That means something is happening in the genetic structure. It can be single step mutation, or it can be termed as a multi-step mutation. Whereas this acquired resistance can be a manifestation of gene transfer, and this gene transfer can be of many types: transduction, transformation, and conjugation. Now, if you look at the pictures, few things will become clear to you. The first one, A, is depicting bacterial transformation. The second one is depicting bacterial transduction. And the last one is showing bacterial conjugation. I am starting with the third one, the bacterial conjugation, which is probably one of the main mechanism for the spread of resistance or even multi-drug resistance if R genes are transferred between different species. The conjugative plasmid that contain the transfer R genes make a connecting tube between the two bacteria through which the plasmid itself can pass. This is commonly observed with bacterial population at high density, as in the gut, because the resident microflora can serve as a reservoir for the resistant genes, which can be transferred to other organisms that later invade the host. Next come to bacterial transduction. It's a less common method of transfer of resistance, by which this plasmid DNA enclosed in a bacterial virus called bacteriophage is released and transferred to another bacterium of the same species. In the previous one, it can involve different species, but here it is usually the same species. It is usually observed in the transmission of resistant genes between strains of staphylococci and between strains of streptococci. So, one most important difference is the presence of bacteriophage virus, and second most important difference is the conjugation can be seen within different species, whereas this one is mostly restricted to same species. And next comes bacterial transformation. This method is for developing resistance. It's probably having the least clinical problems. It involves the ability of certain bacteria to pick up free DNA from the environment, and then this free DNA, it is usually from a cell belonging to closely related to the same strain. New DNA is then incorporated into the genome of bacteria, which then becomes resistant. So it's a release of DNA. There is no such presence of bacteriophage virus. They have released the resistant one. The resistant one is going inside the recipient cell and it is incorporated in the genome. So out of the three, which one is the most dangerous one? Bacterial conjugation. So all the multi-drug resistance we are seeing in our clinical practice, or the kind of thing we are observing in perspective of difficult to treat resistance, are mostly related to bacterial conjugation. Now, when you are trying to explain the thing in terms of a cell, bacterial cell, where the drugs are not being able to work properly, how will you remember the main causes of or the mechanisms of antibiotic resistance? There are different mechanisms, and you can start it from the very beginning. Beginning means the drug is not being allowed to penetrate the cell. So that is going to be the first problem with the drugs. in relation to bacteria. Think about penicillin. Think about the structure of gram-positive and gram-negative bacteria. Normally, penicillin is effective on gram-positive bacteria, so they can penetrate gram-positive bacteria, but they are not being able to penetrate gram-negative bacteria. So these drugs, penicillins, are basically resistant to gram-negative bacteria. The second thing is, whenever the drug is being able to penetrate inside the cell, inside the bacterial cell, they will try to find out a target. The target can be anything. Most of the times, for example, in case of penicillin, it is penicillin binding protein. So if the target is modified, the alteration of drug target may lead to antibiotic resistance. So that is the second reason why after penetration, drug has to bind with something so that it can work inside the cell to destroy the bacterial cell wall or any other structure, or it may have to inhibit DNA synthesis. But if it cannot bind with its target, the action is going to be ineffective. And such example is again lying there. Alteration of penicillin binding protein. When penicillin is coming inside the cell, it is not being able to bind with the penicillin binding protein. The third one is, the drug is present inside the cell. Probably it is being able to bind with the target, but it is modified or it is destroyed. The drug itself is destroyed by drug inactivating enzyme synthesized by these virulent bacteria. It is seen in case of Staphylococcus, it is seen in case of Pseudomonas, it is seen in case of E. coli. So there are a variety of different resistant types of bacteria, like ESBL variety, where you will see extended spectrum beta-lactamase enzyme is responsible for destroying the drug like penicillin. So the enzyme is synthesized by the bacteria, and these enzymes are responsible for destroying the drug, and hence the drug is not being able to work properly. So that is the third cause of resistance. The fourth cause, I used to term it as vomiting. That means the drugs are coming inside the cell, but the cell is vomit out these drugs via an drug efflux pump that is seen with chloroquine. If you see the resistance of chloroquine in case of malaria, or if you see the resistance of sodium stibogluconate in case of Kala-Jar, you will see this mechanism that the drug is coming inside the cell, but the cell, either by changing pH or by changing, by certain mechanism, the help of some kind of use of some kind of pumps, which can be anything like glycoprotein like pump, it will efflux out whatever the amount of drug is going inside the cell. Hence, the drug is not going to be effective on these bacteria. So these four are the common mechanisms of antibiotic resistance. Repeating it once more, the bacteria is not allowing the drug to come inside. Even if the drug comes, it is not binding with its target protein because the protein is modified. So alteration of the drug target. formation of drug inactivating enzymes. That means antibiotic destroying enzyme is synthesized by these bacteria, and drug vomiting, which can be seen in case of few drugs due to the modified efflux pump in the structure of the bacteria. So whatever may be the amount of drug present inside the cell will be effluxed out, will be vomited out by the same bacteria. So here I am giving few examples. Reduce intracellular concentration of the drug, inactivate the drug. The inactivation of beta-lactam antibiotics by beta-lactamase. It can be a short-acting, it can be a long-acting one. Prevent uptake of drug. Prevention of aminoglycoside entry by altered porine channels. Porine means it's the water-soluble channels, and aminoglycoside is basically a drug specific for the gram-negative bacteria. So for penetration inside the gram-negative bacteria, if the structure of the cell wall, porine channels are must. Promote efflux of drug, efflux of multiple drugs by MDR membrane efflux pump, and I have already mentioned about chloroquine in case of malaria and sodium stipogluconate in case of collagen. Target-based mechanisms where the alteration of drug target is seen, expression of altered peptidoglycan that no longer binds vancomycin, similarly alteration of penicillin binding protein which no longer being able to bind with penicillin, and bypassing metabolic requirement for the target. It is not being discussed in the previous slide. The inhibition of thymidine synthesis bypassed by exogenous thymidine. This is a kind of rare one, target-based mechanism, but this is also seen, though I have mentioned about the modifying target for the drugs. It can be seen due to various reasons.